Now it's a great honor to me to introduce a friend and a colleague, senior colleague who has been here for a long time, worked in very busy places and considered one of the best in the country. Dr. Sherif Bakir, he's a consultant adult cardiologist. He works in KidsHeart in Abu Dhabi and in Dubai, and he is going to talk to us about pregnancy with heart disease. So, welcome, Dr.
Good evening, or afternoon, or whatever. It's a great honor and a pleasure for me to be with you today. And I have now to change. It's okay, the mic is on. I have to use this one. I have to change the gear now. All the before was the fetal, now I will go to the mother. For ladies, I don't want you to misunderstand me, but this is when we deal with female, this is the engineer how to look to. Men is very simple. Female are very complicated, and we have to know that. Male can only concentrate in one item, but female can listen to her husband, look to her daughter, she can know everything. So the mentality of the female are difficult. So why cardiovascular adaptation to pregnancy is needed? This is very important to understand the mechanism during pregnancy, and then you will understand why there is a difference. First of all, 30 to 50% increase in cardiac output, stroke volume increase during pregnancy. So if somebody have a normal heart, it's okay. Somebody have abnormal heart, this is not okay. Not okay, but it is a load. The second thing, 40% increase in the blood volume. So this is also a load for the lady. Decrease in the systemic resistance. Also, this is another story. And hypercoagulability state. The pregnancy, normal pregnancy, will lead to that. Then, male and female, we have to understand if we compare male and female. The difference between testosterone and estradiol is one H group. One H group can make you like this or can make you like this. So we have to know the simple change. Any simple change I will show you to you. It is very important. So this paper published 10 days ago. They said like this, that association of maternal caffeine consumption during pregnancy affects the child growth. So just, and not caffeine, not too much caffeine, a very small amount of caffeine. Why I am showing you this paper, which is published 10 days ago? It is to tell you that this is a very critical time for the ladies and for the babies. The second thing, association of the maternal cardiovascular health in pregnancy with offspring cardiovascular disease in health early adolescence. What happened during pregnancy will not affect your baby after delivery. After 12 to 15 years, your baby can suffer from what happened to you during the delivery. So this is very important. This paper published 1 year back. So to understand how the critical is the delivery time. This is another paper. Increased cardiovascular risk in offspring of mothers with poor cardiovascular health. So when the lady decided to be delivered, it's not only just because she wants to deliver. We have to be sure that she is cardiovascular risk are normal. Day after tomorrow, I will talk about the cardiovascular risk. I am sorry to tell you, 40% of you have cardiovascular risk and they don't know. And I will show you day after tomorrow. This is advertised for my next lecture. Okay, to avoid this situation, just to follow the guideline. We have to know the guideline. What is the guideline? There are a lot of the last guideline for the delivery was 2018. I saw the guideline for fetal, it was 2014. So we are a little bit more advanced. It is 2018. This is the only guideline which we have from the European Society of Cardiology, and this is the Russian guideline. So why are these guidelines important? Why the guidelines are important to us? Simply because I think one of the speakers, he said, I think Dr. Suleiman, statistical significance does not necessarily imply clinical relevance. So you read in the paper, yes, you saw something like that, but does not mean once you are doing the trial, it will be translated immediately to what you are seeing. So why are these guidelines important? Because pregnancy is complicated by maternal disease in 1 to 4% of cases, which is very high. Cardiovascular cardiovascular disease are the most common cause of maternal death in Europe. Hypertension affected 5 to 10% of all the pregnant ladies. And I will show you during my talk that there is a paper published recently, maybe 12 days ago or something like that, that preeclampsia does not affect only during the pregnancy time. It will continue after that. I will see it in the end of my talk. Knowledge of the risk associated with cardiovascular disease during pregnancy and their management is very important for advising patients before and during pregnancy. But this is very important. Sorry. The number of cases is too small. We have no statistic. I cannot do trial. So the problem is we don't have a very solid objective find in our hand. So this is clinical experience. If you depend on clinical experience alone, you are making the same mistake every time. If you depend on the evidence base, you are making somebody else's mistake. Why? Because we don't have clear studies on the deliveries, on the pregnant lady. So it is not one size fits all. We have to understand this. For this picture, this is William Osler. He said that variability is the law of life. As no two faces are the same, no bodies are the same during normal. So during the abnormal case, which is disease, nobody like each other. We have to understand this. I bring the picture of male. I don't want to bring a picture of female, obese and tall and so female will be angry with me. But this is to say that our aim is to prevent, relieve suffering, and this is our aim. Now we'll go to the guideline, general recommendation. This is the guideline. Counseling and the essential management. Now, counseling and risk assessment. So, risk assessment have been mentioned by one doctor, I cannot remember his name. He said that risk estimation should be individualized, depending on underlying the cardiac diagnosis, ventricular and valvular and function. You have to do the risk assessment. Number 2, in women with moderate to high risk, now we have what is called the WHO classification. It is very complicated. I will show one slide for it because it cannot fulfill in a 25-minute lecture, but we have to know. Everybody have mentioned the pregnant heart team. Now this have been mentioned very strictly in the guideline. It is not single-man job. We have to understand it is a complicated story. Cardiologist, obstetrician, anesthesia, genetic, it is a complete story. Once you try to talk about cardiovascular disease in pregnancy. A delivery plan should be made between 20 to 30 weeks of pregnancy. The plan should be very clear. As Dr. Suleiman said, when he do the fetal echo, the parents, the patient, everybody knows what he should do and when and how. The plan should be very clear. So, what is new? Why the guideline every now and then it's changing? You know why? Because female have been changed. This is the female of yesterday, and this is the female of today, and this is the female of tomorrow. You became a mudir, so the female have been changed. This is why now we have a new guidelines. Females have been changed. So now we'll look through the selected, this is what's new. I will go very quickly. It is recommended to perform risk assessment for everyone. And it is intervention is recommended before pregnancy. If someone has something need to be intervene before pregnancy. Before they said and upgraded class 1, now the new guideline have been changed completely from 2012, 11 to 2018. Intervene before. And during the second and third trimester, they said about that recommendation for the warfarin and these things now have been changed. I will not go in detail because no time. But this is the WHO classification. It's very complicated, but it should be read and everybody should know it. And to have to classify your patient. For example, sutalol was not now, it have been taken. For example, flecainide and propafenone are recommended to prevent supraventricular. Because everybody was using sutalol before, but now have been changed. Low molecular weight heparin is the drug of choice. And this is very important because unfractionated heparin was sometimes used. So we have to understand this. In pregnant women on low molecular weight heparin or unfractionated heparin, it is very important to do for them factor 10. So this is also something of the new change. Another important point is FDA categorized replaced for new drug by description risk summary because we don't know anything about the drugs. This is to have to understand that. Pregnancy is not recommended in patients with severe dilatation of the aorta, heritable thoracic aorta, or anything, or bicuspid aortic valve with more than dilated aorta. So this is very important. You have to understand this. Another important point is right heart catheter is recommended. Don't be afraid of that if needed. You have to do it before. And also, the treatment dose for low molecular is recommended in pregnant patients with chronic thromboembolic hypertension. This is very important. Of the guideline have been changed. This one is very also woman at high risk for thromboembolic obesity. It is recommended to convert low molecular to unfractionated 36 hours before delivery. But if it is low risk, we can change it to 24 hours performed after the last dose. So depending on the risk. Another important point is it is recommended to manage pregnancy in women with mechanical valve in a center with pregnancy heart team. This is very important. Mechanical valve, don't do it in, as Dr. Salman would say, yes, with all respect to all other private or whatever, but you have to do it in a proper place. This is also very important in patients with history of aortic dissection, cesarean delivery should be considered. We have to understand this. Another important thing is beta blocker therapy through pregnancy should be considered in women with Marfan syndrome. All through, she have to be on. And induction of labor to be considered at 40 weeks gestation in all women with cardiac abnormality. Now, patient with peripartum cardiomyopathy, now there is a bromocriptine. I have no experience with this bromocriptine, but it has been shown that it is a very good drug. And they said this is for the patient for treatment for a patient with peripartum cardiomyopathy. This is very important. Pregnancy is not recommended in patient with vascular Ehlers-Danlos syndrome, and the breastfeeding is not recommended in whom take antiplatelet agent other than low-dose aspirin. This is very important to put it in your mind. This is the bromocriptine. I have no experience on it. It is a new drug for peripartum cardiomyopathy, but it is available, not available in UAE, but I have no idea, no experience on that. Now, new information on the pharmacokinetic in pregnancy, more detailed information on the pharmacodynamic in animal experience and all drugs, but still, as I will show you some of my slides, that now there is some change in our mentality with dealing with the drug. We have to know that there is drugs that are considered safe, drugs are not considered safe, but all of this we don't have sure objective finding because it's difficult unethically to do a trial. But don't forget, drug does not work in patient does not take them. So if the patient needs the drug, he has to take the drug. So we have to understand, and as you will see, all women with congenital or other possibility genetic heart disease should do offered fetal echo in the week 19 to 20. I saw in the presentation they can make it early, 11 to 13, but according to the European guideline 2018, they said it is better, it's much easier to be between 19 and 20. Now, a delivery plan, as I said, should be made between 20 and 30. This is very important. And managing of labor, delivery, and postpartum surgery. Induction of labor should be considered at 40 weeks. We mentioned that. Vaginal delivery is the first choice all the time. And indication for cesarean section, we can go through it, but very important to know that severe pulmonary hypertension, this should be cesarean. And pregnancy termination should be discussed. If there is a high risk of maternal mortality or mortality and or fetal mortality, I think the doctor from Cornish, they said after certain weeks we cannot discuss that, but in Europe they said it can be discussed anytime. Now, pregnancy and consequently fertility team is contraindication in women with class WHO class 5. You have to understand. This is why you have to know the class 1, 2, 3, 4, 5. As I told you, it's a complicated one, but you have to know it very well. All patients with known cardiac or aortic disease need investigation and counseling about the risk of pregnancy, pre-pregnancy, or before assisted reproductive therapy. This is very important. The following patients should be counseled against pregnancy, which with Fontan operation, severe systemic ventricular dysfunction, severe coarctation, systemic right ventricle, which Ehlers-Danlos syndrome, severe aortic dilatation, all this, they should not be pregnant. And also with severe mitral stenosis, this is very important. Severe mitral stenosis, even if it is asymptomatic, they should not begin pregnancy unless you correct it before pregnancy. And this is very important because in the Middle East and India, Pakistan, Egypt, we have a lot of cases with mitral stenosis. When you have to know that symptoms is not the criteria to decide yes or no. And patients with severe aortic stenosis who are symptomatic or asymptomatic patient with impaired, now the aortic stenosis, there is difference between the mitral. Mitral, we said, even asymptomatic, they have to be done and corrected before. While in aortic stenosis, there is some debate. But the idea was, if the patient who are symptomatic, or the patient with asymptomatic but with left ventricular dysfunction. If left ventricular fraction does not normalize in women with previous peripartum cardiomyopathy, don't allow her to become pregnant. Women with a mechanical valve prosthesis are at high risk of maternal morbidity, especially valve thrombosis and bleeding. As we said, pregnancy by itself increases the coagulability and even mortality, and should be managed and by pregnancy heart team in expert center, even if they are having well pregnancy time. It is very important to understand this. Low molecular weight heparin should only be used when weekly monitoring of factor 10 level is adjusted. Otherwise, no. To do use unfractionated heparin. But the problem, unfractionated, to have a lot of bases, lot of cases which have been developed problems. They are mitral stenosis on oral anticoagulant. They stop the warfarin because it is more than 5 milligram, and they put on under unfractionated heparin, and the problem, they have a lot of infection and a lot of problem. So now, if you want to do low molecular weight heparin, because it's much easier, but you have to know that you have to repeat factor 10. So women with heart failure during pregnancy should be treated according to the current guideline for non-pregnant patients. You have to understand this. Respecting contraindication for some drug in pregnancy, but we have to know that sometimes in emergency situation you can use the drug which are contraindicated in pregnancy, as I will show to you. Sorry. So it is recommended to inform women with dilated cardiomyopathy and heart failure with reduced ejection fraction about the risk of deterioration of the condition. I have found one of my patients, they have delivered 3 times in spite that postpartum cardiomyopathy on the first time, and their ejection fraction was 15%. And in spite of that, they are coming and delivered. But with the treatment, she improved. In women with peripartum cardiomyopathy and dilated cardiomyopathy, subsequent pregnancy is not recommended if left ventricular ejection fraction does not improve. If it is improved, yes, we can. And the patient with congenital long QT and the catecholamine are recommended beta blocker during pregnancy and postpartum. This is very important also. Initiation of antihypertensive, this is the very important point. Initiation of antihypertensive drug treatment is recommended in all women with persistent elevation of the blood pressure, gestational hypertension with or without proteinuria, pre-existing hypertension with the superimposed of gestational hypertension. All this have to put it in one. As I said, eclampsia and pre-eclampsia and hypertension during pregnancy, it's up to 10%, so it's very important. Women with at high or moderate risk of pre-eclampsia should be advised aspirin, 100 to 150 daily from week 12. This is very important. And this is paper published just maybe, I think, recently. I cannot remember, maybe a few weeks, 2 weeks, or June, printed in 21st June 2022, about what? Here the conclusion. Hypertensive disorder of pregnancy and the preeclampsia rate were higher in women with heart disease, but the problem is the combination is in continuous, and multidisciplinary context is important. This patient postpartum they will develop, even as we said that even after the pregnancy finished, they are still at risk. Methyl dopa, labetalol, and calcium antagonists are the recommended treatment for hypertensive during pregnancy. Low molecular weight heparin is the agent of choice for prophylaxis treatment, and thromboembolic treated thromboembolism only used in patients with severe. If severe hypotension, yes, you can do. And in this case, an emergency drug that are not recommended by pharmacological industry, you can use it in the emergency to save life. Care during pregnancy, all women with congenital heart disease, as we said, they have to do fetal echo. Echocardiography is recommended in any pregnant patient with known cardiac disease at 12 weeks. This is very important. And a delivery plan should be by pregnant heart team. This is very important. 20 to 30 weeks should be planned for that. And when anticoagulant is indicated, low molecular weight heparin, I am repeat again, to be used is except, yes, if you are able to do factor 10. Delivery, induction of labor should be considered 40 weeks, and vaginal delivery is the best. And indication for cesarean section, as I said, this is some aggressive aortic pathology or acute intractable heart failure. This can indicate the vaginal section. Endocarditis prophylaxis is not recommended. Is not recommended. And this is for heart failure management. I mean, it's very complicated slide, but just to understand that we have confirmed diagnosis or what. And finally, increasing risk. Pregnant lady is not only hypertension, obesity, dyslipidemia, insulin. By the way, statin have been accepted by FDA to be given during delivery. It was not accepted, but accepted last year. Statin can be given to the pregnant lady. And to finalize my talk, if a male go to buy something from Gap, for example, this is his way. It will take 6 minutes. If female go to buy something, the same from Gap, she will take 3 hours and a half and 26 minutes to buy the same. The male will buy $33. The female going to the same purpose, she will buy $87.6. This is statistic on Gap shop. So, working hard, right tool, this is our aim. Thank you very much for your listening.
Thank you very much, Dr. Sherif, for the interesting talk. Though I have some reservation on the sexiest comments, who are all outnumbered here.